One group was just monitored for 6 months, and all they had was their PCI procedure. The other group, they took bone marrow out of their backs and injected it into their coronary vessels. And 6 months later, they had a whopping 67% improvement in their left ventricular function. What's in bone marrow? Namely your own stem cells and cell signaling factors associated with stem cells. They then studied whether the improvement was due to the replacement of the dead myocardial cell by stem cells, or was it due to some other factor having to do with cell signaling factors improving the functionality of the remaining cells to compensate for the ones that had died. And they found it was the latter, not the former. So they could have left the stem cells out and gotten the same effect, is the point. When the University of Pittsburgh, which is the major transplant center in the United States, read this article, guess what they decided, which is the same thing that I decided. If this is working by improving the living cells as opposed to the dead ones, then this would work better in hearts that are affected but are not dead, rather than hearts that have dead areas. CFIS patients don't have dead areas, and neither do cardiomyopathics. They don't have either. So the transplant center at Pittsburgh, University of Pittsburgh, launched the same study on 10 patients with my disease, in which they, as they present for transplant, they put in the LVAD unit, left ventricular assist device, and they're waiting for a donor while they're on this machine, which keeps you going when you don't have a heart. It assists it. It doesn't replace it, just assists it. And they're going to inject their bone marrow into this period of time while they're waiting for the donor to see if maybe they don't even need a donor. Now, that's systolic failure with anatomy and anatomic derangement of the heart. CFIS patients don't have anatomic derangement of the heart. They just have energy problems. So, just in the same logical sequence, if this works in coronary disease, and it probably works better in cardiomyopathy, left ventricular dysfunction, guess what it probably would work the best in? This disease, CFID. They injected bone marrow, which has in it stem cells, but they concluded from studies later that it wasn't the stem cells replacing the dead cells, but something else in the bone marrow. So, I do not believe it will be very long before someone makes the same leap that the Pittsburgh cardiologist made based on the Tony Drexler study. Someone's going to make the leap that, you know, if this helps this, it might even cure diastolic dysfunction. How much does it take or cost to have your bone marrow injected in coronary vessels? I estimate $3,000 tops. And if you got a 67% improvement in your left ventricular function, you'd be cured of this disease. It doesn't take a lot. Gene expression is physiology. The gene expression producing mRNA, which is taken down by the endoplasmic reticulum into protein and runs your cell, the gene expression as expressed in its reading frames of these messenger RNAs is your physiology. So if you have a disordered physiology at the cell level, you will, I guarantee you, have a disorder of mRNA transcription and translation. It's got to be there because it's always there. Gene expression is physiology, and physiology is you either have Q or you don't. Q is cardiac output. What's in the bone marrow that does this are the cell signaling factors. That's what's in the bone marrow. And what it's doing is changing the genetic phenotype from one physiology to a different physiology, and that different physiology is correcting the left ventricular function. That's what's happening. If you think this is science fiction, this is acute childhood leukemia, and on the left-hand side are the genes, 271 genes from 327 kids, and what the colors you see each dot is an individual gene, and the color of the dot is the relative genetic expression of the gene. The red is high expression, it's being read quickly. The green is it's shut off, and everything between green and red is partially active. So a continuum of expression. So these kids, they had 271 genes expressing according to the dot, and the genes in question, well, these are the genes and these are the kids. And then after they did this is called gene mapping, they then accumulated like groups, and they found that this genetic expression likenesses, in fact, described the known variants of acute childhood leukemia, which are listed along the bottom. Those are the 6 known variants, plus a novel variant they had never discovered before, was predicted by this gene expression map. Furthermore, if you take fancy multidimensional spatial analysis of this data, the kids who were in yellow, who had leukemia, all favorably responded to the chemotherapy of the day and were cured. Everyone in yellow was cured by the therapy available for the day. If, however, you were in red, you would always relapse, even if you got the therapy that cured the others in yellow. And when you relapsed, you went from red to green, and then this group over here developed a complication of leukemia, acute lymphocytic leukemia, namely acute myelogenous leukemia. So in other words, the gene map done before treatment predicted the outcome of the treatment with great precision. The point of this is obvious. When we start doing this, and I'm sure we'll be doing it, I think if we gene map patients and then see what the outcome, which subgroup you're in, we'll be able to predict which of you would be cured by the bone marrow and which of you maybe don't. It's not really that difficult. It's been done before. Now, this is just a quick and dirty review of my current basic therapy. It's not so much down to the it's not so much down to the not everybody gets the same thing. I sort of mix and match things. And I'll tell you, it's a work in progress. It always has been. So what I do today will be different tomorrow and different a year from now as it was last year. So it's a movement in progress. I've never developed a protocol. I've never developed any protocol that I truly liked. So I'm always moving on. But obviously for phase 1 immune activation, Ampligen is a reasonable idea in the early phases. Antimicrobial therapy. By the way, why would people with this disease respond to antibiotics when there isn't anything to hit with the antibiotic? Well, if your cardiac output is causing vasoconstriction in the splanchnic and you're getting bacterial contaminants into the bloodstream, you would feel better on antibiotics. So people who think that antibiotics are making them better because they're attacking something may need to think again. It's unlikely to be the case. Immune modulation. My favorite approach here is that give something that can change the immune system toward normal, because I don't know what normal is for that person. So I'd prefer an adaptogenic immunomodulator, and there's several of them out there. The first and one of the better ones I've ever used was Kutapressin. Kutapressin is really an immunomodulator, and it works, it has direct antiviral effects, but it works at a gene level, and it importantly activates bradykinin. One of the reasons I now believe Kutapressin works so well is that bradykinin would be one of the best things to improve microcirculation in the face of heart failure. Therefore, Kutapressin treats diastolic failure and its consequences. Kutapressin was actually first used in Texas. I believe in Houston was the first study ever using that drug. Short of Kutapressin, you can use the equivalent today, which is the Atrium liver product. The Atrium liver, which is basically ground up liver, spun down in a centrifuge, low molecular extracts, frozen off, and you take it orally rather than inject it. You can actually inject it. If you injected the Atrium liver, you would be injecting Kutapressin. It's made the same way. My current immunotherapeutic therapy is isoprinosine, or Immunivir. And Immunovir is a very interesting product. Do you know what one of the side effects of Immunovir is? It raises uric acid. And if you raise uric acid, you scarf up peroxynitrite and decouple one of the principal players in this. So maybe that's why it works. I mean, I don't know how it works, but it's a pretty good immunomodulator. Anticoagulant therapy, especially if there's a risk of immune-stimulated acquired coagulopathy in the family tree, mother, father, aunt, uncle, brother, sister with early myocardial infarction or stroke should really consider anticoagulant therapy. At a minimum, some of the fibrinolytic agents, like nattokinase and lumbrokinase.